little bit of paper in here too. You have started all that block, so just
Oh, you better not do that.
it's just words.
So I've just pressed record. One of the things that we're doing for milestone 1, well, did you see Tasha's email saying
want to
that
record the feedback.
all of the feedback we want to record, which just means that's an extra half a day of reviewing feedback now for me, but that's okay. How'd you go, mate?
I felt flustered, especially when whoever was trigger happy with the vomiting, kept on doing that. But I felt confident that I was able to recognise it, reset, manage that, and go back. I felt that was good. Watching the video, I might not have felt calm in the process at times, but it appeared calm. It appeared in control. It appeared, I spoke to Tristan briefly, that with my communication and my inclusion with you and what I wanted to do and things like that, good. And he certainly reflected that, yeah, it was. He always felt like he had direction.
Yeah.
I think that was positive. I think I walked in and without wanting to just take the ACP's handover, I was able to very quickly go, I want to do a rapid primary survey myself. Let's do that for my benefit and my system that I've fine-tuned, and I thought that was done nice and succinctly.
Yep.
And then as we progressed, I then started to tick off components of my secondary survey that weren't included in that primary. I thought that was one of the positives I did.
Yep.
I think I labelled it reasonably quickly, but then got distracted with certain elements, whether it be we've got to roll and clear the vomitus out, so therefore I tasked Tristan to get IV access. That took a lot longer than what you'd ideally want in the ideal world. So, but I think in the face of adversity, I was able to reset and recompute that sort of stuff. My biggest downfalls was probably duly recognising some small, I would like to try and reflect small equipment, skill, procedural things, i.e. the giving set. To pull out a used one and just do that and then prime my burette and had the volume in there, but then didn't even think, truthfully reflecting, let's flow that through, recognised the cue and then turned around and managed it, but yeah. That was frustrating and it took the better part of 3 or 4 minutes that I was playing with that, which was time wasted on there that probably shouldn't have been wasted on there. I felt in comparison to when you were up here last time, I labelled I'm going to do a tube, I want you to sit here and ventilate, thank you very much, you can do that.
Yep.
I went out the back, I had my mat, I pulled my checklist out, I used it, I stepped my way through it.
Yep.
It wasn't until I was doing the skill that one little word in the bottom corner with an arrow that says tube tie wasn't there. So that was another one that I duly recognised that missed in that component of it.
Yep.
And then lastly, that watching the video and reflecting back on it, I haven't gone back and played with that mannequin. That blade was probably the right size. I troubleshooted quite well in reaching, no, I've got my second one there, I'm ready to go. I just parked in the second blade.
Yep.
But that probably should have been done first time rather than reaching for the second. So that's how I felt with that.
So, if you're given the opportunity to do it again, what would you do the same? What would you do differently?
I think I'd come in and do my primary survey and my tasking is exactly the same. I think I did that well. Differently would actually just be when doing select procedures, stop, slow down and just do the deed. Don't get caught up in the emotion of it's a sim, it's being an assessment, it's a PED or whatever the case may be. Just slow down, take that breather and go, recognise that this blade's right for this patient, change something else or whatever that position was. That's what I would do differently. That'd be the biggest thing that I'd do differently.
Cool.
I tried to, and I think it's supported with the checklist. Recognising the vomiting, I needed to secure that airway. That was my goals or my primary bang for buck treatment. However, I wanted IV access before I performed that skill. So that's why I pushed more towards I want that IV access done. And I think, especially when you watch the tape, and I didn't even do the tube until the better part of about 16 minutes.
I think we had 18 minutes on ours, yeah.
It was just, that's too late. That is too late in that sim. But then, I sit here and try to conflict with myself. Why did it take me that long to get that?
Yeah.
And for me, it was playing with the giving set. It was, you got a line in, yes, you eventually got a line in, no way, oh, we've got an vomit, got to reset and go back to that. And you kind of forget to realise how much time just flows by.
So, and some of the information provided to you came out. I'd agree with you. You acquired information early, and you stated what your plan was early, and like you said, you know, that's an improvement from 2 weeks ago. Absolutely. And we all commented on that when we sat down and said, oh, you know, how do we go with communication and planning? You stated your differential early, and you said, here's what I want to do. I guess the question comes around, like, if your number one priority was I need to secure the airway, and it takes 18 minutes to secure that airway, what is it that led to that 18-minute kind of process rather than not securing it earlier than that? And I think you identified that, some of the task distractions or task fixation elements in there. So, how did you go with doing your mini CX?
I stepped my way through it and tried to just truthfully reflect on it. You know, I did parts of it before I watched the video, and I amended it a bit as I went through, and then did more as I went down. So I felt my clinical knowledge in recognising algorithms. You know, up until this point in time, I'd been relying on cheat sheets in the back of my iPad for tube sizes.
Yep.
You know, and thanks to Dean, I was able to sit down and go, no, I'm calculating my tube size this way. This is a formula.
Yep.
That's did it. And I've even since looked back on my cheat sheet that I pulled out of the paediatric reference guide in the CPM, the
Yep.
DCPM. No, that was the right size. It was the right length of the lips. It was
Yeah,
just
absolutely.
so I think that was
You
a very big confidence. So
you stated the right size tube. You identified that the parameters of vital signs within that setting indicated a severely shocked patient, which you verbalised. We gave you an independent for that score in terms of clinical knowledge, and that's coming in anatomy, physiology, pathology, evidence-based practice. How'd you go?
I'm an assisted on that one.
Okay.
The policy knowledge, you know, now that I'm talking a bit more about it, you know, the fact that I had to go back and change the giving set and do things like that, I probably upskilled myself there, unfortunately. I marked that as assisted because I marked myself down in procedural skill competencies as dependent further down. But that's certainly, you know, that doesn't belong in the assisted mark, you know, reflecting on that here now.
So now that you're reflecting on it, where do you think you'd sit with that?
The giving set, let's not say. The fact that I even connected a giving set, I might not have opened it, but
Yeah.
I connected it and then cut it off and pulled it off when it was probed. But if that was a real case situation, that's unsafe.
Yeah, and when we reviewed, there were a couple of things that were reviewed in there. The discussion was about, is this a procedural thing where we're just reusing pieces of equipment within our kit? We kind of said, well, even if that's the case, the same principles of Ruby's rule and priming giving set need to be attended to within that setting. And then within there's also policy statements around pieces of equipment such as the burette, how the burette runs, such as, you know, when you've got that closed port up the top, you're creating a vacuum, which means running that line's going to be an issue, which kind of led into some issues with troubleshooting down the track because we didn't demonstrate competency with that piece of equipment. So I'd agree with you that policy knowledge is unsafe in that setting, particularly the priming of the line. There are lots of bubbles within that setting. All right, and you were given a fairly significant prompt to square that away. How'd you go with your safety manual tasking?
I marked that as assisted. I felt no issue with that.
Yeah,
PPE was used, everything was appropriately done.
I think it's better than assisted. I think you show good independent practice in that setting. You're a role model for safe practice. So we gave you an independent for that score. Well done.
History taking, I think, was markedly improved
Yes.
on previous stuff. You know.
I'd agree with you. Yeah, absolutely. How'd you score yourself?
I'm actually aiming for assisted, so I've marked that as assisted.
So we said it's on par with where you should be at the moment, which is assisted. You certainly got information from mum, but there are a few other things that you could have got. So you started appropriate history taking, is he taking any medications? But we could have completed more of a history taking element there. So when mum said, hey, I had a sore belly yesterday, then like that's your systems prompt to go, all right, listen, has he had vomiting or diarrhea? Did he complain about the pain? Where was the pain? And if you asked that information, you would have been provided with, he was saying it was over in his right iliac fossa, and you could start thinking along the pathway, what's the pathology down that pathway? So while you're on track, and certainly that is a significant improvement, there is still a little bit room to move in terms of following up on those questions when their information's been provided to you. But in terms of where you need to be at, absolutely where you need to be at in that area. So next element was physical exam.
Again, I think in my systematic approach, which ties into the very next point, I think I did that head to toe. I covered each of the systems off in my assessment. You know, they were GCS 3, so I wasn't able to do a motor sensory function test or a neurological assessment, but I was able to auscultate. I did the head to toe, I had Tristan exposed, and I had that verbalised to me. So I've marked both physical examination and the systematic approach as assisted.
So physical exam you completed, I thought it was good. You got you asked relevant questions, you inspected and you palpated. I thought it was fine. So we gave you independent in that. Well, I think it's at expected standard for what we'd want to see, not only in this milestone, but you know, for the remainder of the program as well. Your systematic approach, we said it was assisted, which agrees with yours. Started very well. Well, I think we were all really impressed with how well you came into that room and kind of went, hey guys, here's my primary assessment, here's my secondary assessment, this is what I want to do, here's how I want to achieve it. So your systems were good and they were going really, really well until you hit a couple of hiccups, and then that ability to go back and review and work through systematically, you know, what was in front of you could have been improved a little bit, but saying that you're at assisted, mate, which is on par. You asked for your blood pressures, you asked for your feedback about end-time CO2, you regularly went back. So the small bits of improvements there would be to, when you do an implementation of a skill, then you go back and you say, all right, what's my vital signs? Am I seeing a trend to support that? No, this is appropriate within that setting. Cool. Interpretation of vital signs. How'd you go?
I think they were right. No, I didn't turn around at any given stage and say, right, that particular one, heart rate's too low, his blood pressure is, no, heart rate's too fast, but his blood pressure's too low or anything. I didn't label that, but in my head, it formulated the evidence to support where I was going, you know, the fluid administration and that sort of stuff. I was able to, in my own head, recognise that it was deranged. You know, it was febrile at 39 degrees, you know, which supported my septic pathway that I was thinking in my own mind and things like that.
And you said it to your team. And the thing that I liked, because it's something that we worked on in the CDP support sessions, is that once you see it, you label it, and then you provide that information to your team. They knew what they were treating, and we did too. So as a facilitators within that setting, we go, yeah, absolutely. So interpretation of vital signs, good. Well, we gave you independent in that area. Well done. All right. Development of working differential diagnoses.
I think I was a bit better than the last time I had a paediatric sim with you, that I didn't just walk in and label something and anchor entirely off that. I think I completed my systems, I completed my assessment, I completed a bit more evidence to support a plan.
I would agree with you.
You know, I think, you know, I didn't just walk in, he's unconscious, he's time critical, I need to do something to manage that now, because, you know, 8-year-olds shouldn't be unconscious, or you had vomiting in the soiled airway, that sort of stuff. But I didn't just reach for going, he's unconscious with the soiled airway, I need to secure that airway. I was able to sit back and go, no, I need to formulate other things, I need to do other things before I get to that, to make that safe as well.
Yeah, so like I think you put the pieces together and you wrapped it up very early, saying this is what I've got, and you said that to your team. I agree with you. Like you put the pieces together, probably the pieces were put together, and then when we get into the management side of things, there were a few things in the management side of things that delayed getting to where you wanted to get to within the time frames. But mate, in terms of putting the pieces together and developing your working diagnosis and consideration of individuals, I thought it was very good. A big improvement from last time, so well done. All right. Management planning and implementation.
I think I labelled it and I formulated my plan early. I verbalised that plan early.
Yep.
I marked that as assisted. Just the fact that I was able to step through my secondary survey, I got to a point where it was literally, all right, this is what I want to do. I want you to do this. When you've done this, let me know. And then we sort of rolled through that plan. It was just, I hit hurdles, whether it be, and Julie recognising a change in the patient's condition too. I heard the vomit.
Yeah.
And it was right, let's roll and manage that. I'm not going to ignore that sound or not going to affirm that sound. Let's just roll and deal with it. And then unfortunately that, with each time, I didn't time each particular time how long it was, a minute or a minute and a half or whatever, but it just chewed up time, because I'd literally be, Tristan, I want you to get a line. Yep, okay, no worries. Oh, he's vomited, like, help me do this.
I think we were looking at, when we set up the SIM, about 3 minutes, so 3 to 4 minutes between vomits, and then when there was no airway management processes, there was a couple of prompts just to prioritise or identify that airway was becoming an issue. So I'd agree with you that your planning was good. It's the implementation that I think was below the required standard at this stage, and that points to things like we've got a profoundly shocked patient without IV access or fluids administered before the 10-minute mark, and a patient that you identified as needing emergent airway support didn't get an ET until the 18-minute mark. And in amongst there was some once you had third person on scene, I think, was it Drew?
Yeah.
Drew arrived, the tasking of, can you draw up some ondansetron? Now, ondansetron for this patient is going to have to take time to work. But what's the number one priority for you when you've identified that there's a little bit of right-sided congestion and ongoing airway compromise?
I believe I was setting up the tube at that time, or all but setting up the tube at that time.
Yeah.
But my priority of care would have been performing the tube,
Yeah. And so for me as a facilitator sitting back, the tasking of ondansetron when there's an emergent airway issue is something that I sit back and go, should be all hands paying attention to the correction of the airway. And the prioritisation of ventilation or oxygenation while the airway is being set up to. Because I believe that you had Tristan assisting with fluids or something along the pathway there. For me, ondansetron within that setting, yeah, it'd be something that you give after everything's been taken care of.
Squirrel.
Do you think that's a fair comment, or? And sorry, the implementation probably around the provision of fluid administration comes back to the knowledge of the equipment. So we had some issues with the burette there and the line. Procedural skill competency is probably the area that leads into. How do you think you went in that area, Ben?
Oh, look, to use the checklist, to label the tasking and things like that, I think that was much improved. But then to have the frustration with the giving set,
Yeah.
I even tried to verbalise it with the bag. I would not ever re-spike a bag for the sake of what the equipment I've been running in the training kit.
Yeah.
It was that's what I've got. I wasn't just going to turn around and go, I've got a bag of giving set with a line, let's just use that. No, it's a paediatric patient.
Yeah.
I'm not going to be ever comfortable or happy with running 300 mils off a 500 mil bag into a paediatric patient.
Yeah.
So, I marked myself as dependent on that one. Yes, I required prompting and that was probably not okay, but, I felt that it was more improved. Even down to the tube tie and the blade with the tube, with the airway clearance at the beginning. The procedural skill competency wasn't at the independent or assisted level, because that should have been squared away first and foremost.
Yeah.
But I think I was also able to, it comes along down further later on, troubleshooting and problem solving. I recognised an issue, let's fix it. I was able to bounce back off that. No, don't get off the rails completely.
Yeah.
But just fix that and move on.
So for